During this presentation, we'll be talking about delirium and dementia. We're going to compare and contrast features of delirium and dementia. These are the main topics for this presentation. Then we are going to we'll be talking about common psychiatric disorders in geriatric group, that's old age group, and the comorbidities that are in this age group, and the different treatment options that are preferred in old age group. So moving towards our first slide, that's aging. So aging is a normal process, and with the aging process, weight of the brain, these are for certain facts. Weight of the brain decreases. In the radiological examination, we do observe gray and white matter changes. The IQ of the person declines, and as well as there are some problems regarding problem-solving skills, and the memory decreases. There are so many medical comorbidities that go along with the age, and there is a loss of, and beside these, the psychosocial issues that come along, there is the loss of status. A person who has his status during his young and adult life, in the old age, there is this loss of status, and the person become independent. Independence is lost. He is dependent on all others caregivers. So there is a loss of independence, there is loss of status, and in some cases there is loss of spouse, which in itself is a huge burden. Then comes the unemployment. With the unemployment, again there is a dependency, and as well as the isolation thing. We'll be talking about it later in our presentation. As far as the assessment is concerned of the old age people, assessment is always multidisciplinary. We need to have a detailed history from the patient as well as the family and the primary caregiver who's taking care of the patient. A detailed history with the old age patient if he is coming with memory issues, so there will be little difficulties. Therefore, the account of family and caregiver is must. Moving along with the history, we need to have a full physical examination of that person. As we talked about that there are so many medical comorbidities, so we don't want to miss those, as well as there are some, we cannot skip neurological examination, so we need to have a detailed neurological examination to see is there any focal signs. Mental state examination is the main component of psychiatric history. History is not complete without mental state examination, and specifically in the old age population, we need to have a full cognitive assessment. We need to see how his cognitive faculty is. So for that thing, beside that cognitive assessment, we'll be assessing the functional, there'll be a functional assessment. How a person is behaving, how a person is doing his daily activities, like feeding and like taking care of himself or herself, and as well as there is social assessment. In the social assessment, we usually acquire the information about his accommodation, where is he living, and his financial and legal matters, how he is managing these financial and legal matters. Then, and this is the history of the patient, and then we cannot just skip or ignore the caregiver. We need to get a history assessment of the caregiver's need. What are the needs of caregivers who are taking care of this old age patients? We need to know the relationship of the caregiver with the patient and the amount of care that are provided to the patient by that particular caregiver, and what sort of care is he providing, and the duration of the care that he is providing, the degree of stress that caregiver they are under, because of this cognitive decline, the patient as well as the attendant, the caregiver, is under enormous stress. And we cannot just ignore that stress of the caregiver, because if you're going to ignore the stress of caregiver, then that stress the caregiver will project to the patient. So we need to address that caregiver. Then there is understanding, and then we need to know what does this caregiver understand about the illness, because most of the time the caregiver, they feel like this is the normal aging process, and in this aging process people do get irritable. So there is no need to for a doctor or such interventions. So we need to know what are their and what is their understanding of the illness, of the symptoms. That's really important in this case. So moving towards our first topic, that is delirium. It is also called as acute confusional state. So if somebody asks what is delirium, we can say that it is a stereotype response of brain to a variety of insults common in hospitalized inpatients. So you can see there are three main things that you need to focus in that line. So what is delirium? It is a stereotype response of brain. So that's a response of brain. Response of brain to what? To variety of insults. And these variety of insults will be the etiology, because all those etiological factors, all those insult, when they occur to brain, the brain responses, and this is really common in hospitalized inpatients. So these are the three main things that you need to keep in your mind. So what sort of insults are there? That could be infective, that is respiratory tract infection, urinary tract infection, or there could be metabolic like uremia. It could be intracranial if somebody is experienced and gone through like a cerebrovascular accident, or there are some endocrine issues like hypoglycemia, hyponatremia, and in case of substance intoxication or substance withdrawal, they can also be, these all are these insults that when happen to brain, there are brain responses, and that's quite common in hospitalized inpatients. Beside that thing, you also need to understand, you need to keep in mind the following 3 points: that delirium has always acute onset. So there is always an acute onset with delirium, and there is fluctuating cognitive impairment, or you can say that fluctuating consciousness. So at one moment, the patient will be, you'll see that he's responding fine, he's responding to your commands, he's talking. And at the other, like after an hour or so, or even after a few hours, you will see that he's acting so weird, and he's not conscious, and his cognitive functions have declined. And there are other behavioral abnormalities, that he become irritable, maybe aggressive, and he try to move here and there, wander around. So these are three, again, these three are also important points. So what is the epidemiology of these delirium? This is, as we discussed, this is really common in medical and surgical inpatients, almost 10 to 20%. And the risk factors for this delirium are a person who is elderly, a person who has pre-existing dementia, or he has some sensory issues like he's blind or deaf, as well as if he has comorbidities like any other infection he's going running around. And if and in the burn victims, they are really prone to go to this condition, that's delirium, and it carries significant mortality, that is up to 20%. So out of 120 people who are hospitalized inpatients, they die. So that's really high number. Coming to the clinical features of the delirium, if you see, it is impaired ability to direct, sustain, and shift attention. As we said, that there is cognitive issues in the delirium, so the person will be having difficulty to maintain his attention to a certain point. Then there is global impairment of cognition. A person has problems with attention as well as concentration, memory, judgment, and abstract thinking. There will be difficulties in his memory, but that's quite different from the difficulties of memory in dementia that we'll see later on. So mainly there are problems of attention as well as there are problems or there are issues with global impairment of cognition. There is disturbance in sleep-wake cycle, uh, and a person sleeps, has a broken sleep mostly. Then there's perceptual distortions. A person with delirium, they do experience illusions and hallucinations, mostly visual. As we said that they have behavioral issues, that's here over here mentioned, that they experience agitation. The onset, as we already talked about, the onset is acute or onset is rapid with fluctuating in severity over minutes to hours. The impairment, that global impairment of cognition that the person will experience, fluctuation in it ranging from minutes to hours. How will you manage the case of delirium? If somebody asks you what's the management of case of delirium, then the first answer that you should be giving is you need to identify the cause first. What were the etiological factors? You need to identify what is the causative age and causative factor in that particular case. You need to identify and treat the cause. As soon as you will treat the cause, this delirium, the person will come out of this phase, come out of that condition that is delirium. Beside treating the cause, you need to give supportive measures. That first of all, you need to educate the family. If you don't educate the family, it will be a huge mess, because at one point the family will see that their patient is perfectly fine, and at the other moment when the patient's condition will deteriorate, as we talked, so the education of family is must. Then comes the safe environment. Safe environment over here means that there should be proper ventilation, proper as there are sensory issues in this case. So, and patient become agitated, so you need to see the patient might not hurt himself, and the lighting is proper, and usually there should be a clear communication. Uh, if you are talking to that person, you need to talk in a higher tone so that the person can understand uh, properly. And we need to avoid sedation unless severely agitated. So most of the time, benzodiazepines are used in such cases, but the guideline is you are not supposed to sedate those patients, because unless a patient is severely agitated. And when you are going to review, when you're going to see how much the patient has improved, there is a scale that is called mini mental state examination, MMSC, that assesses the cognitive function of that patient. So you need to identify the cause, you need to give supportive measures and avoid sedation, and then regularly review or check. Now we are moving to our next topic, that is dementia. In the dementia is again, it is concerned with global cognitive deficit. Delirium was also concerned with was disturbing global cognitive deficit, and the dementia as well. But the main difference is the dementia is progressive and is usually irreversible. How? Often the first symptom that a patient presents with in dementia is memory impairment. However, that is not the only presentation in dementia. Patient may present with dysphagia, difficulties to speak. Patient may present with difficulty to identify his own body parts or name. His difficulty in taking or wearing his clothes, and there is difficulty in executive functions, and there are personality changes in some cases or some types of dementia. The main types that are irreversible causes of dementia, they are vascular dementia, then comes the Alzheimer's disease, Lewy body dementia, and frontotemporal dementia. These are the most common dementias that are irreversible. However, there are certain other causes, there are certain other uh, in these conditions, the patient may present with the features of dementia. However, they are the reversible causes of dementia, such as subdural hematoma, normal pressure hydrocephalus, vitamin B12 deficiencies, metabolic causes, and hypothyroidism. In all those conditions, patient may present with dementia. So, if a patient is presenting with cognitive decline, you need to assess in these lines, or you need to have the history, as in our second slide that we discussed. You need to have a detailed history so that you can reach to the proper cause of that cognitive decline. The clinical features in the cases of dementia, as we said, memory is the most common presentation, and in the start it is usually the short term memory that has declined first, and leading to long term memory in the severe cases, or in the prolonged or old cases. In the short term memory, he will be a patient will be will become unable to say, like, if you have given him the food, he won't be remembering that he has taken meal. And if he kept something on the table, he will just forget what he has kept on the table. Then comes the personality changes. In that person, the caregiver will tell you that he is not the same person that we saw before, a few years before. He has completely changed now. A patient with dementia usually socially withdrawal. He is disinhibited, and he is diminished self-care and apathetic. You'll see a person who is now socially become withdrawal. He's not going to meet people. He has remained within himself and disinhibited. He is joking around, which was not in his personality. The anxiety and depression is quite common in such cases. 50% of cases of dementia, they do have anxiety and depression. Hallucinations and delusions are quite common in the cases of dementia. Often there are paranoid delusions that the person will feel that the people are against me. Mostly the patients with dementia, they'll complain that all my kids or my children are after, or all these relatives are after my money, and they are going to harm me. Then there is sundowner syndrome in the cases of dementia. That means that as evening approaches, there is increase in confusion, and and there are falls that become common, which patient usually results in fracture. So how you are going to manage a case of dementia? Assessment is mandatory. And in the assessment phase, you are going to diagnose what type of dementia he has, and then the level of decline, that's the functional and social decline, that comes in the assessment phase. Then, if you have major diagnosis, if you had assessed how much his functional and social decline is, then you are going to give him or treat him with the medicine. That is mostly the medicine that are used are acetylcholinesterase inhibitors, and as well as the antioxidants are always all are used, like vitamin E. Then, if there is psychosis, you need to treat that psychosis as per the guidelines of psychosis, that is usually the second generation antipsychotics. If there is depression, then you will be treating the depression as the guidelines are. usually with the SSRIs, and if there is insomnia, that will be treated accordingly. Then comes the psychological support to both the patient and the caregiver as well. And then the functional management. For the functional management, you need to maximize the mobility. As we said that the person becomes socially withdrawal, you need to make the most that a person mobilize. You have to encourage the patient become independence, at least with self-care, so that he can use toilet without any support, and he can eat, he can have his meal without any support. So that's the area minimum you need to focus. At least he should be independent in that areas. Then comes the social management, because in the Western societies, when the person are living alone or in old home, then you need to be sure that he has the proper accommodation, and he has the functional, he is functional to take care of himself. So the accommodation, where the person is living and how he is managing, that's important. Then comes the activities. What are his activities for the day, and what are the financial, and how he or she is managing his financial and legal matters. So what are the differences between dementia and delirium? These on your left side, you will see these are the characteristics on which we compare what are the difference between delirium and dementia. So the onset, the delirium has an acute onset, and the dementia has a slow, progressive, insidious onset. The course of delirium is fluctuating. At one point, the cognitive functions are pretty fine, and at the other, they just decline. And in the case of dementia, there is gradual deterioration. The awareness or the consciousness in the delirium, that's impaired. However, in dementia, that is usually preserved. The awareness, patient is aware of his surrounding. Attention, that is disturbed in delirium. However, it is preserved in early cases of dementia. The memory is usually the memory is disturbed in both the cases. Poor working memory, however, in the dementia there is short-term memory issues. The delusions are mostly short-lived or changing delusions in the delirium. However, in dementia, there are fixed delusion. If somebody has a paranoid delusion, he has a fixed delusion, is that particular person is against me. However, in the delirium, that thing changes. If a person is visually hallucinating, then at the second moment, he won't be visually hallucinating. There are sleep disturbances. In the delirium, there is fragmented sleep, a broken sleep. A person sleeps for 1 hour, and then he's up for 2 hours, then again he sleeps for 1 hour. And in the dementia, there is sleep-wake reversal. Mostly the patients are up in the night and they are sleeping whole day. These are the main features or differentiating features of delirium and dementia that are most important. And then there is differentiating features between Alzheimer's and vascular dementia. Vascular dementia is very common in our part of the world, although that is way beyond the scope of fourth year. But if somebody is interested, we'll just take a minute to discuss that thing. So, in case of vascular dementia, there is a history of atherosclerosis disease. That's must, and that's less common in the cases of Alzheimer's disease. The onset of vascular dementia is sudden, or it can be gradual, but in the Alzheimer's disease, it's always gradual. The progression of vascular dementia is slow or stepwise progression. Like a person is working fine, and then is abrupt episode of dementia, abrupt decline in the dementias, and then again the patient will maintain that score of that score on mini mental state examination. However, in the Alzheimer's, that is slow and progressive decline at certain pace. The neurological examination, obviously, there is when there is a brain insult. So, neurological examination, there will be neurological deficits with vascular dementia. And however, in the Alzheimer's, there is no such neurological deficits. The gait is often disturbed early, however, the gait is quite normal in Alzheimer's disease. So these are the main differences. And if somebody asks the type of dementia, so Alzheimer's comes under the cortical dementia, and the vascular types comes under the subcortical dementia. These are the main features. As we said, that it is way beyond the scope of fourth year, but if somebody is interested, you can just check it out. So as far as the other psychiatric disorders that are concerned in this age group, so the most common psychiatric disorders that are in this age group are anxiety and depressive disorder. The presentation is same. There's low mood, decreased interest, or decreased energy. However, in the anxiety, there is a patient has physical symptoms as well as neurological emotional symptoms in the anxiety. The psychosis present with the same with hallucinations and delusions. There is substance use is common in the old age because in order to relieve this depressive disorder for the short term, or in some cases there is dependence on the substance use. Suicide, there are the studies are there is rate of suicide. There is suicide is quite common in this age group, and the most risk factors for the suicide are increasing age, a male gender, if a person has already suffering from a physical illness or a depressive illness, as well as a substance use, or a patient or person is widowed or a separated or is socially isolated. All these features are they are the risk factors, and they increase the chances of suicide. Elderly abuse is quite common, that is 4 to 6% in such cases. And usually the person an old person with older age is dependent for his financial matters, so he is abused financially by the caregiver, and he is emotionally abused. Socially, a person is already isolated, so that's again is used against him. The caregiver, if the caregiver has mental or substance use problems, then that might increase the chances of abuse of that old age person if the caregiver has already a substance use problems. Then there is an absence of suitable guardian. If there is no guardian, a proper guardian with the patient, then again the chances of abuse increases. So that's the last slide. And that covers the prescribing of in the elderly. There are that in this slide we'll be discussing the general principle that if you are going to prescribe a medicine to an older age, how you will going to prescribe. So the first principle is whenever you're going to prescribe a medicine to a patient with older age, a person with older age, you need to start with the lower possible dose. Lowest possible dose because of the slow metabolism. And if you're going to increase the medicine, you need to increase that that increase should be slow, because the chances of side effects are quite common in this age group, and there are sedation, postural hypotension, and the chances of extrapyramidal symptoms are the elderly patients are quite sensitive to them. So the dystonia or the pseudo-Parkinsonism, they are quite common, Parkinsonian features. And you need, as we said, that the person with the older age, they usually have medical comorbidities like hypertension, diabetes, arthritis that are quite common, and they'll be taking medicine for that thing. So if you are going to prescribe an antidepressant, you need to be careful for the drug interaction. For the atypical antipsychotics, as we said that for the if a person is in psychosis, then atypical antipsychotics are better tolerated than the typical antipsychotics. That typical are haloperidol and trifluperazine, and the atypicals are risperidone, olanzapine, and quetiapine. SSRIs like selective serotonin reuptake inhibitors and norepinephrine reuptake inhibitors are generally safer than tricyclic antidepressants. SSRIs comes with the name of fluoxetine sertraline. So they are quite safe and the first line drugs that should be used than the tricyclic antidepressant, which has side effects of postural hypotension and excessive sedation. You should always consider the risk of suicide in all old age. You cannot just miss this risk of suicide in that cases, because they do. If they are going through a physical illness, if they are in pain already, they might go for